All right. New exciting things in physical activity and public health! Exclamation mark. Talk a little bit about state and local planning, the research that Dr. Elliott and I are doing, and then spend a little bit of time talking about crystal ball, where I see things going in the next some years in terms of what we need to learn to actually make a change in the population level of physical activity in the United States. We're not talking about increasing training levels or everything, but moving the prevalence of people meeting physical activity guidelines, at least 150 minutes a week of moderate intensity activity on most days of the week, moving that prevalence to a point where the health of the population is increased. And I'm too far. This is fun. You can't wander around. There. I guess you're stuck with me over here. First exciting thing that's happened. How many people have heard of the Physical Activity Guidelines for Americans? How many people have heard of the second edition of the Physical Activity Guidelines for Americans? Okay, great. So we're out there. I was honored to be part of the inaugural guidelines that came out in 2018. The second edition, 10 years later, were just published in October. And they are have the full weight and confidence of the federal government behind the scientific recommendations for physical activity and health. In other words, much like vaccine recommendations, much like the dietary guidelines, other kind of things that the federal government recommends be done is here with physical activity. And we hadn't had these before. Before 2008, they didn't exist. I think that's an elevation of the importance, an understanding of the elevation of the importance of physical activity for health. So there's some new things. There's an expanded science base. The edition has moved, here we are, has moved to include some guidance for physical activity recommendations for preschool age children. The initial ones began only at age 6. There's a large discussion of sedentary behavior and its role. Is it truly the opposite of physical activity, or is there some interaction between the number of hours you sit and the physical activity behavior in which you participate? The original physical activity guidelines recommended a minimum of 10 minutes at moderate intensity. The science no longer supports that necessarily. Any physical activity counts towards the 150 minutes of physical activity per week. Even more health benefits, as well as some acute benefits. And then they also included some strategies for physical activity promotion. If you go to health.gov/PA guidelines, you can download this current information. I'm particularly proud of this work because all of a sudden this has been elevated to an important topic enough for NIH, the Office of Disease Prevention and Health Promotion, and CDC to take a lead and make key guideline recommendations for health promotion. Any activity counts. There's no threshold, no lower threshold for benefits. This very famous curve that graphs leisure time physical activity or met hours per week, and then mortality on the y-axis. Very clearly, there's really no threshold. We got a steep early slope, and then it continues to go down a little bit at a time, but there's no obvious best amount where we actually start to see this benefit in a lower risk of mortality. Most benefits seem to be attained here, but some early benefits can be attained even here in terms of less than 10 met hours per week. And they're immediate. So the first realization of the data from one of the things that had happened with the physical activity guidelines in 2008 is they sparked 10 years more of research. They allowed us to try to fill a lot of the holes that we didn't know existed back when we reviewed the literature in 2008. And a lot of what came out of that effort was this the fact that there's no, sorry, I'm not very facile with this, there's no seemingly lower threshold of benefits. Lots of new studies at less than 10 minutes at a time, lots of new studies at less than 30 minutes a day. Those kind of things came out in the wake of the 2000 physical activity guidelines and allowed us to understand that area in between 150 minutes a week and zero. So this relationship still holds. We had that in 2008. But now we're starting to understand these acute benefits very close on, and there's no really obvious threshold where you have to get to have these benefits of lowering risk, in this case, lowering risk of mortality, which is perhaps the ultimate outcome of interest. There's new evidence in improving quality of life in the short term, reducing anxiety, reducing acute blood pressure, not reducing risk of hypertension, but actually blood pressure reduction, insulin sensitivity, some sleep outcomes. A big change or addition is in what we're calling brain health now. More long-term benefits in cognition for youth, or adults with lowered risk of dementia, including Alzheimer's disease, and as well even management of improving cognition among those people with dementia, MS, ADHD, and Parkinson's and others. So the evidence base has expanded. It's one terrific thing that the research that began with the 2008 guidelines has allowed us to keep filling these holes in. Key guidelines. Kids 6 through 17 years should do 60 minutes a day or more of moderate or vigorous physical activity, aerobic, muscle strengthening, and bone strengthening activity. That hasn't changed since 2008. Adults, first of all, should move more and sit less throughout the day. Some physical activity is better than none. Notice there's no specific guideline for sitting time. You will see in other the Canadians particularly have come out with sitting less, don't sit more than 2 hours at a time, or take a break every 2 hours from sitting. There's really no data to support what those health effects might be. I think they and others have gotten out ahead of the science in that particular case. But we think that there is something to reducing sedentary behavior. 150 minutes a week, moderate intensity physical activity, 75 minutes a week of vigorous or some combination of the two is what adults should participate in for substantial health benefits. More is better. Beyond 300 minutes or 5 hours of moderate intensity activity a week, walking an hour a day for 5 days a week, and then muscle strengthening activities 2 or more days a week. Fundamentally haven't changed. The only thing that isn't there from the 2008 guidelines is there's no 10-minute minimum. In other words, you got to do it for at least 10 minutes to get health benefits. And importantly, older adults were, in 2008, it was the first time that we actually included specific recommendations targeted at older adults. There was actually some very strong data on randomized controlled trials on balance training, musculoskeletal training for lowering the risk of falls in older adults. These haven't changed either. Adults should do multi-component activities. If they can get up to 150 minutes a week, they should do that, or they should do as much as they allow. The guidelines also include a section on chronic health conditions, people with chronic health conditions and adult with disabilities, really for the first time, talking about people with diabetes or cancer or things like that. That literature has also expanded tremendously in the last 10 years. Okay, so physical activity guidelines, the first cool thing that's going on. They're hot off the press. If you're not familiar with them, please take a look, because I think they, from a public health standpoint, help us tremendously to understand the targets, what we're trying to aim at. Everyone says exercise is good, but the guidelines help us to get a target for where we need to be as a population. This is a fun painting. Flemish painter, children's games in the 1560s here. Lots of physical activity, lots of kids playing. just a happy, happy photo all the way around. All this kind of stuff. Maybe looks like they're doing something nasty to this guy, but they're still being physically active. Advance to today's situation with the help of a little computer editing. Where have all the kids gone? Where have all the people gone? Screens, televisions, computers. There's one guy here who looks like he's running away with a loaf of bread or something. In the period of time that we've been working, even in the last 40 or 50 years, we have engineered opportunities for daily physical activity out of our lives. Some people from the CPAS building walk to Chick-fil-A. Others drive. It's not any reason, any fault of the people who drive. It's just there's no way to get across. We haven't.
Not me. You know, I drove to Chick-fil-A. There's a marsh there.
But we made it hard. We made it hard for Eloise to get across. And this is this realization that we've got much more to understand about physical activity promotion than telling people, well, you should be active. Right? Physical activity is important. Go exercise. It's good for your health. It's where we started some years ago. A very clinical approach. Someone who is not healthy or not exercising enough, a physician would come in and say, you really should get more exercise. We didn't really know what that meant from a public health standpoint. You can teach people how to swim, the analogy goes. You can get them so that they keep their head above water, but if you throw them in a raging river without a way to get across the other side, it's going to be really hard. We can teach people how to walk and be active, but if there's no way to cross the parking lot safely, if there's no lights at night, if there's no sidewalks, what's going to happen in the environment in which those people live? Right? They're going to get in their car and drive to Chick-fil-A. It's a real problem. And this is what we've done here with changing our environment. I'm not going to give up my remote control, by the way. I love my remote control, or my iPhone. We've got to figure out ways to put it back in. We've got to figure out how to modify the environment, modify policies. You know, one really smart guy once told me that public health, and this is, I hadn't really quite gotten it until my mid-career, public health is that which we can do as a society, collectively, that we can't do individually to improve our health. Fluoridating water supplies, cleaning the air, cleaning the water supplies, taking trans fats out of the food supply, motorcycle helmets, seat belts. Where's in physical activity, our fluoride? Where is our seat belt that will allow us to make that change from a population standpoint to make it easier for people to be back and be more physically active? That's the challenge in physical activity and public health. I think I've skipped some slides, which isn't good. No, maybe they're just a little out of order. So this brings in public health planning. From a clinical standpoint, doctors do this all the time. What's my treatment plan for approaching this patient? How do I get this patient back well? How do I get him through his heart disease or her through her cancer and allow her to have a high quality of life for the remainder of her life? Public health does the same thing. It just focuses on populations. How do we develop plans, right, to prioritize, balance, and allocate resources on a population level to address the population health burdens. That goes from emergency response to hurricanes, to tornado response, all the way to chronic disease prevention and control. Public health preparedness and planning allows us to do that. It can happen at the micro level, the local responders, the meso level, in this case states or territories, or on the national level, macro. All of them work interchangeably or interactively together. One isn't better or worse than the other. If it is in fact done correctly, the local, state, and national planning should work hand in hand or fist in glove to be able to maximize or reduce population health burdens. We haven't done that for physical activity. We haven't done that. We're still at a local, less than local, an individual level, largely. An individual level for helping people become more physically active. And I'd like to argue that we need to start doing public health planning much the same way we do disaster relief and chronic disease control, other kind of things for physical activity and health. We published a special issue of The Lancet in 2012 that had, in fact, this nice painting on the cover. And the essence of it was we proclaimed, we meaning me, proclaimed physical inactivity a pandemic. When you think of pandemic, you think of, you get Zika virus, and you got nasty things that are transmitted by birds and other kinds of things, right? Bats. In fact, physical inactivity can be classified since it is a global problem, and it is an important problem that carries with it a high relative risk of mortality. So thinking about physical inactivity as in terms of a pandemic allows us to say, well, we better plan for this. We better say, hey, how are we going to stop this from continuing to affect populations? Whoops. Not really good at this. Why is that important? Some perspective on public health problems that may be equivalent. If you do some calculations and you come up with one of the epidemiologist's favorite calculations, which is the population attributable fraction, which is essentially the number of deaths or the number of cases of a disease that would be prevented theoretically if the exposure was totally wiped out. So you suddenly make everyone stop smoking. That's gone. Wave your magic wand. How many deaths would be changed? Or how many deaths would be averted? If you suddenly make everyone who's inactive to meet physical activity guidelines, how many deaths would be averted? Smoking's the evil empire. We've been against them for a long time. You'd think that there'd be a huge difference there, and there's a huge effect, but the estimated effect of removing physical inactivity from the population is nearly identical to removing smoking from the population. 5.3 million deaths in 2009 could have been averted had everyone in the world magically become physically active. It's estimated from relative risk, prevalence, and some other kind of assumptions. It's a planning tool rather than a real number. But even if it's 1 million off from smoking, which incidentally is identical to smoking that other people have calculated in the same way, even if it's 1 million off, it is a public health problem. It's as important as smoking. That's the elevator talk, right? You hear this? Some crazy guy just told me physical inactivity is absolutely every bit as important as quitting smoking. And I think it is on a population level. I think it is from a public health standpoint. It appears to be every bit as important. Why aren't we responding the same way that we do with smoking? Why aren't we taxing the chairs you're sitting in like we tax tobacco? Why aren't we taxing cars and fuel, making it harder to be sedentary. That's another lecture. But we're doing all that for smoking. We're banning kids under 21 from buying cigarettes. Kids under 21 not drive? Will that work? Probably not. Thinking about physical inactivity in the same way as we have other public health problems is long overdue, I think. And we have to start training ourselves to create this as a public health problem, both for ourselves as well as the thought influencers we try to influence. Well, one of the things that has started, and I'm very pleased to be part of, as well as Eloise, is the first national plan for physical activity and public health. Has anyone heard of this? A lot fewer, right? I'm not surprised. It's not very sexy. Oh, that sounds great. Let's go work on a national plan for physical activity. Call me when you're done. In response to the first physical activity guidelines, when the recommendations came out, the targets came out, lots of smart people sat around the room and said, okay, now what? How are we going to improve population levels of physical activity? How are we going to attack this to actually move the needle? Not just make you more active or my mom more active or the PE classes more active for children, 30 or 40 kids at a time. But how are we going to actually move the entire needle? How are we going to float all the boats higher? And that's what the National Physical Activity Plan is designed to do. Well, if you've got a public health problem, you got to know what to do about it. You can't just wring your hands and say, it's a public health problem, let's move on to the next thing. One of the nice things I like about public health is that it's an action-based science. You got to do something. The last line in the research paper usually isn't more research is needed in studies involving public health. It's usually this action is needed to be taken. It's a long developmental process. Even before the guidelines came out, some of the early recruitment was being done. The initial development of the first plan began right after the guidelines. 2010, the first plan was released. A 501c3 came shortly thereafter to take management of the plan forward. An update was initiated in 2016, the second revision of the physical activity plan came out, and that's what you'll see on the website. So it's just a couple of years old right now. It's more up to date. It was an iterative process, obviously, from where we began in 2007. Just kind of looking around the table and saying, now what do we do? Lots of organizational partners, which is, I think, one of the strengths of the National Plan, of the National Plan Alliance. Diabetes, heart, dietetics, pediatrics, cancer, strength training, Shape America, many of you were involved in. You can see there's an awful lot of support among organizations that have a similar interest or a vested interest in getting people more active or understanding physical activity. Absolutely critical, these community partnerships. 7 overarching priorities are kind of bold. Establish a federal office of physical activity and health. There is a federal office of smoking and health at CDC. If physical activity is every bit as important on a population level as smoking, shouldn't we have an office of physical activity and health? I submit yes. Comprehensive surveillance. How many? That's what I do. I'm an epidemiologist. I count things. That's the only thing I can really do. But from a surveillance system, there's a lot we don't know in physical activity. So establishing this comprehensive surveillance system for kids, adults, older adults, and the like. Report card reporting, policy development, a national campaign supporting development of state and local plans. We'll come back to that in a minute. And advocating for increased funding. These are the overarching priorities that drive the National Physical Activity Plan Alliance. It's every bit as important as smoking. We've got to put the efforts to it. So what the plan has done, I think, and I hope it comes across. If it doesn't, the only thing I'd like for you to take away from this talk today is that more of the same is not enough. Understanding how to get 1 or 2 or 3 or 30 people more active for a semester or a year or even 5 years isn't enough. We've got to be thinking population level, changing the 320 some odd million people we have in the United States right now to make them more physically active. These are on the other side of Easter Island. You got to think differently. We can't just keep going the same way we've been going because the needle hasn't changed. And the National Physical Activity Plan is one of those ways that we're trying to think differently about approaching this physical activity as a public health problem. It's an incredibly complex behavior. I struggle being physically active every day. People think it's a simple thing. Oh, you're trapped? Solution seems right up in front of you, right? No problem. Except when we don't consider the entire system in which we're living. He hadn't considered that when he pushed the first block over. And he's about to find out that pushing that block over really didn't help him much. It might actually hurt him. The same idea goes with complex systems, understanding complex systems. And where we are now, and what the National Physical Activity Plan is helping us to do, is treat this as a systems problem and not just an individual behavioral problem. Sidewalks, the raging stream, the gully or the marsh in between CPAS and the Chick-fil-A, right? I asked first thing, I've been here a few times, but I asked Eloise the first thing when we got in the other day was, this is a hilly campus. How do students walk from class to class? And I don't remember what you said. Not much is what you said, right?
So they take the PRT. I don't know what I said.
Take the PRT. You're not going to level the hills in Morgantown, West Virginia, but there are ways around this. We have to be thinking of how this is a complex behavior and how to overcome it. This is a little out of order, just a sec. Yeah. Requisite stairs and escalator slide. Everyone's seen them. I took this at the 2013, this was in the Moscone Center in San Francisco. Nice convention center, big group of people. The 2013 American College of Cardiology annual meeting. These are smart people. They're telling their patients to go get more exercise. But there's a queue to take the escalator. There's only 1 or 2. I'm sure these guys are all going to go to the hotel gym or go out and run along the Golden Gate Park at the end of the day, or not. Point is, this isn't to cast aspersions. It's an incredibly difficult behavior. When smart people, whose job it is to take care of hearts, take the escalator rather than the stairs. It's not as simple as just building stairs and they will come. And you can't get any more convenient than putting stairs right next to the escalator, unless you turn the escalator off. Incredibly complex behavior. Single environmental changes aren't the solution. Single policy changes aren't the solution. Individual behavioral changes aren't the solution from a public health standpoint. A systems approach is what we actually need to be able to attack this, I think. Now I'll go back to these, sorry for the distraction. What we've done so far, we have a problem. We've got a group of kids that we want to get more active. We We apply some behavior change theory or some kind of way to intervene or develop an intervention. We do that intervention, they change. You publish your paper, you get tenure, you get congratulated by the dean, and you get another grant, and you keep going on and on and on. Congratulations. Environmentally, do a policy or environmental change. Let's say you put a sidewalk in, you do the intervention, and you get a behavior change. You publish your paper, you get tenured and promoted, the dean shakes your hand, and you move on to the next thing. You maybe get another grant to do another thing. The point is, nothing has changed in the population that you were, and maybe in the ones you were studying. But in the overall population, nothing has changed because we've been focused on these single interventions rather than the system in which we all live. And I think to make the, what's the word I'm looking for, to make the jump, to be the innovation in what we're trying to do, we've got to get away from just this single level intervention work and be starting to think about our systems approach to physical activity. So we take that last set of slides and reorganize it a little bit. We've got a problem and a solution. Behavior change theory, environmental change. Notice I don't have intervention here. It's strategies and implementation rather than an intervention. Uh-oh, what's all this stuff going on? We got education, health, planning, built environment, transportation, workplace, sport and recreation. Every one of us interacts in multiple sectors, if you will, or multiple parts of our lives. Every one of us interacts in the transportation system. We sit down on, was it University Avenue at the four-way stop, and we can't seem to go anywhere every day because there's so many cars going by there. We're in the education system, parks and rec, all these other kind of things. There's room in every one of these areas to generate a system-based approach to physical activity. Not just when you're at the gym, right? Not just in the sport and recreation sector, but in the city planning, the built environment, the transportation sectors, even in the health sectors. And then be thinking more instead of cause and effect or pushing one box over and saying you're done. Be thinking about things such as things that might accelerate or delay the intervention. It could be 12 years before a sidewalk that's put down in a neighborhood starts to pay off in terms of increasing people's physical activity. That's a lot longer than the standard 5-year R01 from the National Institutes of Health. Can't study it the way we normally do. There could be things that inhibit it. People could make adaptations to changes that might get in the way or increase the likelihood of physical activity. Competing actions, one of my favorite things. I was on an IOM panel a few years ago talking about comprehensive school physical activity and making some recommendations. And a colleague of mine who is a lot smarter than I am, she was the Miami-Dade vice superintendent for PE at Miami-Dade. Huge job, big school district. And she said, well, we got to consider who's going to be against us in terms of these recommendations to promote physical activity in schools. I said, who could be possibly against kids being more physically active in schools? She said, the music and art teachers. Because their budgets are getting cut too. And I hadn't even thought of that. They would be working against these ideas. So a systems approach understands that and tries to figure out how to embrace the people who might be against these changes so that we're allowed to make what we need to make to help kids be more physically active. It's an eye-opening experience. Physical Activity Alliance, the National Physical Activity Plan, works in 9 sectors. more than I had listed there. Parks and rec, education, business, faith, churches, and synagogues, public health, and mosques, mass media, sport, healthcare, transportation, land use, and community. All of these sectors have committees, they have strategies, they have tactics to achieve their strategies, and are working to start to roll these things out. 2016, it's a brand new kind of document and so forth, but that's where we are with the National Plan Alliance. Hello from Austin, Texas. The bats are out. If you haven't been there, please join us. You can wear your West Virginia t-shirts too. Everyone does down there. That was a joke. No one's laughing.
They're very quiet.
Yeah, what's going on here? We started to take a look at this a little bit. From a public health standpoint, I firmly believe that all health is local. All health doesn't come from physical activity guidelines. All health doesn't come from national physical activity plans. It comes from understanding guidance from national levels, the macro levels, and bringing it to the meso and micro level. So we started off studying this in 2013 with a paper that surveyed a group of people who are members of a group called the National Physical Activity Planning Association. National Physical Activity Practitioners Association, sorry. And just asking them what they know about state and local planning for physical activity. Internet-based questionnaire, 27 questions. About half of them responded. Came back with 227 surveys, and we were asking about their awareness, the importance and barriers of various aspects of their job. First time anyone's ever asked them about their jobs. These are people working in local health departments, in state health departments, in nonprofits, whose job is primarily to advance physical activity in their target population. Most of the people have been on their job less than a year. I'm sorry, this is annoying, I know. Most of the people have been on a job less than a year. Most of the people had a graduate degree, and most of the people were at state and local health departments. Give a view of this group we're surveying. When asked if they were aware of the state physical activity plans and for state chronic disease plans, so many states, most states these days have chronic disease plans. The reason for that is that CDC has funded, through their mechanism, obesity prevention plans, heart disease prevention plans, diabetes prevention plans, cancer prevention plans. And states have to meet some rigid guidelines to get that money to be able to do work at local and state levels. But when asked about the presence of a state physical activity plan or a state chronic disease plan, numbers were all over. So in other words, no, our state doesn't have a current physical activity plan, and I don't know if our state has a state chronic disease plan. Yes, we've got a physical activity plan. Half the respondents said that. And yes, we've got a chronic disease plan. In fact, at the time this was done, there was only one state with a dedicated physical activity plan. West Virginia came on right after these data were collected. So even the people working in this area were not aware of what was going on and what guidance and support they had to be able to advance their work, which is physical activity promotion. A lot of confusion among this group in 2011. Proportionally rated barriers for state plan is very important. 52% said it was important to develop a state plan for physical activity and a local plan for physical activity. And the usual need staff, need funding, political will, and those kind of things. While there was a demand and people said, half the respondents said, yeah, we need this, very few people were tuned in to what resources were available and not available for their particular states. So we came across, we looked at it and said we got some work to do in trying to help educate the group of people. So bring that to what we're doing right now. This is fresh and hot out of the oven. Dr. Elliott and I have been working on this paper for a couple of days now. So instead of asking people what they thought, getting impressions and doing a survey, we thought it would be important to actually do an objective way of assessing whether or not a plan exists and what characteristics of those plans exist for state and local health departments. Colleagues here, Brooke Towner, who's a graduate of this program. That's why I wanted the West Virginia logo, because there's West Virginia people on there. May 17 and 2018 in January in each of the 50 states and D.C. The overall goal was to determine the prevalence and the characteristics of health planning documents, public health planning documents that include physical activity as a critical piece. We defined a state-level plan as a physical document or website that addresses a chronic disease outcome and is designed to provide surveillance of a certain condition, propose public health goals and objectives, and provide a plan for evaluation. So we had a nice definition of what we were looking for, and then we abstracted a bunch of data for analyses. Brooke was one of the 4 abstractors. With 2 of my graduate students, Erin Dooley and Ashley Johnson, were also involved. What did we find? 245 plans out there in that period of time. Wait a minute, there's only 50 states and D.C. Take a look and break it down. 28 of them focus specifically on physical activity and nutrition, obesity, chronic disease in general, diabetes specifically, cancer specifically, cardiovascular disease, overall health improvement of the population. Only 3 of them were actually physical activity and physical education. But there were only 2 programs, 2 plans that focused on specifically on physical activity. And when I started the Texas plan some years ago, the people at the health department took a look at me and said, no, we've already got that covered. It's in our heart disease plan. It's in our cancer plan. It's in our diabetes plan. When in fact what it says is get more physical activity, and not the specifics that are necessary about what the National Physical Activity Plan Alliance is trying to do to move that along. So these data really suggested we have a long way to go. Most happily were published before or after the physical activity guidelines were published in 2008. Interestingly, most were in children and adolescents, were targeted to children and adolescents, and adults. Very few even mentioned older adults. And don't worry about all the numbers here. The point here I want to call out is older adults and adults had goose eggs all the way across the top. When you take a look at whether or not the plan aligned with 150 minutes a week or the physical activity guidelines for guidance for older adults, none of them actually mentioned that. None of them actually mentioned the muscle, bone, and strengthening exercises. None of them aligned with both aerobic and bone and strengthening. No alignment total, 0.
Unless they were in the all category.
Unless they were in the all category here, right. But those that target older adults specifically, this allows us to take a look and say, geez, these plans, these state plans, whether they're chronic disease or physical activity plans, aren't aligning with what we know about the science. That's a problem, right? In the sector approach, very few, if you take a look at the 9 sectors, very few of the sectors of the 245 plans we took a look at that qualified for this analysis with the sector approach, very few just entirely aligned. Look at that. In the sport and recreation sector, youth sports, for example, aren't being used to promote physical activity from a public health standpoint. It becomes a little bit discouraging when the plan is aligned in by these various sectors, but plans that are out there don't mirror that. They don't follow that. So these data, we're going to use these data to try to affect change. All right, the results suggest a need for efforts to more closely align with state planning health documents and the U.S. Physical Activity Plan, as well as the Physical Activity Guidelines. I continue to believe that standalone physical activity guidelines are critical. They will help chronic disease plans. They will help people trying to reduce heart disease in state health departments or reduce cancer. How we can actually make this happen to improve and evolve so that public health is improved by increasing physical activity. Thanks so much for your time.